Welcome to Louisville Lectures Pediatric Emergency Medicine Lecture Series.
All right, everybody, welcome back. We're going to be doing another module today on neonatal emergencies. So this is sort of a part two, as it were, where we're going to be covering some common, what I would call true emergencies that newborn babies might present to the pediatric emergency department with. If you haven't watched part one, it's not required for this one, but part one covers a lot more of the sort of like common complaints that may or may not actually constitute emergencies, but that are frequent presentations to the ED. So we'll dive right in. And again, we'll start with a case. So this is case two. You're working in a rural emergency department when a mother presents with her 2-week-old infant. The baby was born vaginally at term, discharged day of life 2, and has been feeding and growing well. Yesterday, they developed some mild nasal congestion and occasional cough. Today, mom felt like they kind of just felt warm and did a forehead thermometer that read 101. Baby has not had any other symptoms, no trouble breathing, no vomiting or diarrhea, no rashes. They've been waking up to feed, acting like a normal baby. Mom does say the 2-year-old sibling at home has a cold. And so this is obviously, again, a very common story that you might hear in the pediatric ED. And so you might start thinking through what other history would be useful to know, but also how do you begin your workup? And so we're going to walk through what that entails in the next couple of slides. Maybe. There we go. So febrile neonates, again, a common reason for presentation to the ED. Neonates in the first 28 days of life are at their greatest risk for serious bacterial infections, which you'll see abbreviated as SBI. And the common pathogens, which hopefully these are pretty well in your head at this point in your training, but you always think about those big three. So group B strep, E. coli, and Listeria. When you think about fever, there's a note here that says remember to adjust for gestational age, but that's actually not necessarily the case anymore. We typically go more based on the child's actual chronological age and not necessarily adjusting, although they do have an increased risk in certain cases if they were premature, and we'll talk a little bit about that. Babies, of course, with infections may present with very nonspecific symptoms. So fever is a big red flag. So any rectal temp of 100.4 or higher. But also remember hypothermia. And I will say that the cutoff for this is a little bit debatable. So different folks and different studies and different publications will refer to neonatal hypothermia using different cutoffs. So the one that I personally tend to use is 96.8 degrees. That's 36 Celsius. So anything under that is hypothermia. But some folks will use 96.5, and there are even occasional publications that will call for as low as 96 to be considered normal in babies. But again, that is one of those things that's a little bit less clear than the exact cutoff for fever. Of course, babies with serious infection can also present with symptoms like irritability or lethargy. And those words are very medical legal, right? So we don't necessarily mean fussy or tired. An irritable baby is a baby that is very difficult to console, that is, high-pitched screaming no matter what the parents do. A lethargic baby is one that, isn't just like sleeping and then appropriately arouses to feed. This is a baby who is not waking to feed, or who you really can't get to wake up even with a lot of stimulation. Or feeding, other changes in muscle tone. These are all signs that may go along with serious infections, but not necessarily guaranteed, but things you can watch for. So when we talk about working up a neonate who comes in with fever, important labs to consider, you're pretty much going to be getting what we would call a full sepsis workup. So you're thinking about getting your CBC and CMP. Of course, you're going to get blood cultures, testing their urine, so getting a UA and a urine culture, CSF studies, plus or minus HSV. And then potentially, depending on their symptoms, you might also think about getting like a chest x-ray, viral testing, things like that. Glucose is always a very important one and is generally included in our order sets. You guys might not think about automatically. We typically will get it no matter what is if we are getting an LP. But remember that especially if a baby is either irritable or lethargic, that hypoglycemia can often mimic symptoms of illness or infection. So checking a glucose is very important to do and generally very quick and easy. So this is our algorithm that we currently use for febrile infants aged 0 to 60 days who present to our emergency departments. And hopefully you guys have seen this before. It's in your handbook and it's probably also on some like laminated cards down in the ED. But you can see that if a baby comes in with a fever, the first question you want to ask is, what do they look like, right? So doing your exam, kind of a quick sick or not sick gestalt from just in the room. So if the baby's ill appearing, if they're working hard to breathe, if they have poor circulation, by which, of course, we mean cyanosis or prolonged cap refill, or if they have any other like high risk underlying chronic conditions, doesn't matter how old they are, anywhere within those first 2 months, they are high risk, and you can consider a full septic workup, including lumbar puncture. If not, if this is a pretty well-appearing baby, then the next question is, are they under 28 days of age? And if the answer is yes, typically that does mean a full septic workup, although there's a little bit of wiggle room between days 21 and 28. So this is a sort of more spread out version of this algorithm that we've adopted even more recently. And I'm going to walk you through it by age. So under a week old, do everything. Blood, urine, viral studies, HSV. So under a week, typically we will always get HSV studies. You get your LP, you start empiric antibiotics, by which we mean typically ampicillin, ceftazidime, or a similar third generation cephalosporin like cefotaxime would work. And then we also do acyclovir in that age group. Those 8 to 21 day olds, still doing your full septic workup, but not necessarily HSV unless they are high risk. And you can see at the very bottom of the algorithm that the increased risk factors for HSV are things like, does mom have a history? So that's a question we need to ask. Have they had fevers like 48 hours before or after delivery? It's an important question. Of course, does the infant have a rash, like vesicular rash, that might indicate HSV? Are they hypothermic, seizing? Do they have any mucous membrane lesions? Or are there some abnormal lab results, such as elevated LFTs, etc.? Any of those things are true. So if they are 8 to 21 days old and mom has a history, if they are 8 to 21 days old and they have that vesicular rash, or if they're seizing, then you're going to go ahead and do the HSV test and start acyclovir. But if not, regular antibiotics like AMP and Ceftaz are fine. Like I mentioned just a minute ago, if they are between that 22 and 28 days of age, we get a tiny bit of wiggle room. You're still going to do most of the septic workup in this age group. So that includes your CBC CMP, a procalcitonin, blood culture, UA, and urine culture. If all of those inflammatory markers are normal, by which we mean their procal is less than 0.5, their ANC is between 1,000 and 4,000 and not higher or lower. They don't have like a massive increase in their white blood cell count, etc. Then in that case, you can decide, or you and your team can decide, whether or not to perform an LP. And if you do, great, get those labs. You can, start empiric antibiotics, but you also have the option to potentially send them home and have them follow up. Patients can be a candidate for home observation in these cases if they have reliable phone access, reliable transportation, they live close. The parent is like, very reliable and willing to go like follow up with the doctor or come back to the ER if anything changes. And they have a pediatrician who can see them, or they can return to the ED within the next 24 hours. If they don't have those things, then of course you can watch them inpatient in the hospital. If they had the normal inflammatory markers and you don't perform the LP, then typically that is the case where you can admit them to the hospital, even off of antimicrobials. You don't have to start antibiotics, but you do want to admit them at least until those cultures start to come back positive. Now, if that baby is 22 to 28 days old and any of those initial labs are not normal, including an elevated procal or an elevated A1C, I'm sorry, not A1C, ANC, then you're going to go ahead with the LP and get those results. And typically, if you're doing the LP, again, you can either start antibiotics and admit them to the hospital versus if all of that is normal, potentially start antibiotics and send them home. Usually, I think for those of us who have found abnormal labs and are getting an LP, then we will typically go ahead and admit them to the hospital. Really, the only ones that like I will generally send home are the ones who have totally normal labs. We don't do an LP, and we send them home, no antibiotics, in order to follow up with their pediatrician the next day. Once you're outside of that first 28 days of life, things get much, much simpler. And in this case, generally between the 29 to 60-day-old age group, we will get the blood work. But again, if all of that is normal, then you can typically observe them closely at home without antibiotics. If their inflammatory markers are significantly abnormal between that 29 and 60 days of age, you kind of step back up into the regular algorithm and do the LP, and then the rest goes from there. The one caveat in the 29 to 60 day age group is that if they have normal labs with the exception of a urinalysis, so if their procal is normal, their white count is normal, but they have some white blood cells and maybe some nitrates or Leucest in their UA, then again, you have the option to do some oral antibiotics and observe them closely at home with good follow-up. As opposed to in the younger age groups, where if that UA were abnormal, you would go ahead and do the rest of the workup and admit them. So a reminder, I've kind of touched on this a little bit, but that HSV is a very high risk viral condition for neonates, and should be considered in any ill-appearing or febrile neonate, but particularly those under 14 days of age and especially under a week. Um, Maternal history can certainly be enlightening if mom knows that she has a positive history of HSV. But generally, it's not necessarily going to be the truth or the case that they have a positive history. Lots of moms may not know that they're positive, and can still pass HSV to their babies. We also see lots of babies who get HSV not necessarily from the mom. They get, a family member with a cold sore who gave them a kiss or something like that. But you're watching out for things like the vesicular skin lesions. You can also consider HSV if you get bloody CSF, but it wasn't a traumatic tap. If they have elevated liver function tests, if they're hypothermic. Again, these are all reasons to consider testing for HSV, whether or not the baby is in the typical age range. And if you are thinking about it enough to do the test, then you are also going to start acyclovir. You never test for it without presumptively treating it, because it really can spread very rapidly and cause very devastating consequences if left untreated. We touched on this as well, but again, in the febrile or septic neonate, I know that like the classic answer that we all learn in like our step 1 and 2 studying in medical school is amp and gent. In the NICU, they will sometimes use those as well, but generally in the ED, we're trying to cover a little bit more broadly. And so our first line is typically AMP and CEPH. So ampicillin and ceftazidime or cefotaxime. Gentle reminder that we should not use ceftriaxone under the first 28 days of life. And the reason for that is because ceftriaxone is very strongly bound to albumin and can cause bilirubin to be displaced from albumin and therefore lead to elevated bilirubin levels and kernicterus. If the patient is truly very ill appearing and you're really worried, like this kid actually has meningitis or sepsis, then you can convert to vanc and cefotaxime, but that's generally not our first line of treatment in most babies. Another reminder that sepsis in neonates can look like a lot of other things, or perhaps a better way to say that is that a lot of other things can mimic sepsis in neonates. So, for example, pertussis, neonates with pertussis can be very ill appearing, have lots of circulatory issues, respiratory issues, fever, hypoxia, poor feeding. Congenital heart disease can also do this. Babies with ductal dependent lesions may present with poor feeding, hypoxia, tachycardia, and hypotension, and look like a septic baby. And then also inborn errors of metabolism. So like your congenital adrenal hypoplasias can also present with very similar symptoms like feeding difficulties, lethargy, vomiting, and seizures. And so a baby who looks ill is one of those really tough ones where you're sort of trying to figure out what's going on, but you can't really rule out anything immediately. And so it may be the case that in a very ill-appearing neonate, you might be working them up and treating them for sepsis at the same time as you're working up and treating them for congenital heart disease or inborn errors of metabolism. And that is not a bad thing. It's just a broad approach until you kind of narrow down what's actually going on. particular infections that can be easy to miss. So omphalitis is something that I don't know that we see a ton anymore. I've only seen it maybe once or twice in my whole career, but it is very dangerous and can be easy to miss. So it's very easy to confuse omphalitis with things like, for example, an umbilical granuloma or a normal umbilical stump. You know, when babies' little umbilical stumps fall off, they often have a little bleeding or they may look a little red. They may ooze. And so the parents come in frequently with like, hey, this looks weird. I'm not sure. Um, but omphalitis is a true serious infection in the skin and the tissues surrounding the umbilicus and the stump, which is not typically the same as what you're looking at with just like an umbilical stump that's fallen off or has a granuloma. So you're looking for things like redness, swelling, drainage, but also like discoloration, like dusky color, induration, so like firm skin in that area. And the reason this is so dangerous is because neonates can't contain this infection. And so it very easily extends into the vasculature of the abdomen, spreads all over the body, and so can be very rapid onset as far as a more serious and widespread illness. It's usually caused by Staph aureus, and so we treat it with vancomycin, typically often with an aminoglycoside for anaerobic coverage, so like a streptomycin or something along those lines. We can also sometimes consider adding Flagyl or Clinda. This is something that can be done with the assistance of your pharmacist, but important just to know that this exists and to keep an eye out for it in a baby who might otherwise not look immediately ill, but who could become ill very quickly. So this is an example of just a normal umbilical granuloma. So that little pink tissue kind of in the middle that's like sticking out of where the stump used to be. They may have a little bit of like whitish or yellowish discoloration at the base, and they may ooze or have a tiny scant bit of bleeding. But you can see that the skin around the rest of the umbilicus is very normal appearing compared with, and I'm sorry, this picture didn't come out as well as I had hoped, but you can see that there is like redness kind of extending from the umbilicus out into the abdominal wall. Much more concerning. Definitely would want to work up and treat for omphalitis. And of course, if you're worried about omphalitis and a potential spreading infection, and you're going to start like Vanc and other medications, if this child is that ill, you're definitely going to do the entire rest of the septic workup, including the blood, the urine, and the LP, before you start those antibiotics. Another great example, one that you can see a little bit better, but you can see the red and dusky discoloration in this case that's much more obvious. All right, and I'm actually going to stop there for this one because I think we've hit close to 20 minutes of me talking, and we will come back with case 3 in section 3 of neonatal emergencies. Thanks.